a new month, and it's time to get your nerd on again. As you've probably guessed, we're going to be talking about choosing wisely, and we're actually going to be looking at ACEP's second list that they published last October. You'll all notice that I called this Part 1. That's because some of these topics have a whole lot of ground to cover, and it seemed like breaking it up into two separate videos would be the kinder, gentler way to talk about them all. Otherwise, we'd be here for a pretty long time. In today's discussion, we're just going to review a little bit of the rationale behind the Choosing Wisely campaign and review 2 of the 5 new recommendations from ACEP in detail, particularly focusing on the clinical significance of these recommendations and the evidence behind them. Choosing Wisely is an initiative that was started by the American Board of Internal Medicine Foundation, the goal being to promote conversations between providers and patients and help patients choose care that is both supported by the evidence, doesn't duplicate other tests or procedures they've already had, and is free from harm and actually medically necessary. When the Choosing Wisely campaign was first initiated, ACEP was a little reluctant to participate. Concerns included the potential medical legal liabilities and the fact that the emergency department is a very unique place in the House of Medicine. However, in October of 2013, ACEP did decide to release its first list, and the first list met with criticism that it didn't include enough big-ticket items in emergency medicine. And so, a year later, ACEP released a second list that included recommendations that all have a very strong evidence basis backing them, and includes more of the big-ticket items that were left out of the first list. So I know right now the question on everybody's minds is, why should we care and why should we pay attention to what Choosing Wisely is doing? Well, the guidelines are evidence-based and they're just good medicine, so it doesn't hurt to know what they are and how to practice with them. We should support these initiatives, though, because these guidelines provide good patient care and will probably save time and money by reducing unnecessary testing in the ED. And let's face it, cost-conscious care is coming soon, whether we like it or not. And if we don't start providing care responsibly ourselves, someone else is going to start making those decisions for us. For fun this month, who doesn't love a little Calvin and Hobbes? And now that it's starting to get warm out, what better way to enjoy Calvin than through some of his snowman escapades? So let's just get into recommendation number 6. Drum roll, please. Avoid head CT in the asymptomatic adult patients in the emergency department with syncope, insignificant trauma, and a normal neurologic evaluation. So let's talk a little bit about syncope. The fact is, lots of people pass out. This is an incredibly common reason for an ED visit. In fact, when was the last time you worked a shift where you didn't see a patient who syncopized? Up to about 1/3 of people will have syncope at some point during their lifetime, and up to 3% of ED visits involve evaluation for syncope or near syncope. The majority of these are not serious, but testing is often ordered for these patients. Now, testing doesn't have to be extensive. In fact, your syncope workup could very reasonably involve nothing more than an EKG and an AccuCheck, and the majority of testing shouldn't be ordered on a routine basis, but be guided by your history and physical examination. Put simply, syncope is what happens when you have inadequate perfusion to the brain, resulting in loss of consciousness and postural tone. Think of it as the body's way of making you get horizontal in order to restore adequate brain perfusion. It's typically rapid in onset with brief duration and spontaneous recovery. Oftentimes, the patient will report a prodrome of feeling dizziness or lightheadedness and may have other symptoms associated with it such as nausea, sweating, feeling hot, tunnel vision, or so on. These symptoms are also typically transient. Syncope can be a very benign process, but there are some potentially serious causes of syncope, such as cardiac arrhythmias, bleeding, ruptured ectopic or AAA, and so on, so it's important to perform a detailed history and physical exam on syncope patients. Near syncope, or pre-syncope, is basically the same process as syncope, but is interrupted prior to syncope actually occurring, so it's basically the prodrome without the actual loss of consciousness. you treat and evaluate near syncope the same way you would work up a patient with syncope. Other differential considerations include seizure, generalized fatigue, vertigo, arrhythmia, dehydration, anemia, hypoglycemia, panic attacks, pseudo-seizures, yada 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 yada. So one of the tricks is actually determining whether your patient actually had syncope. And some of the things you can ask them to find out whether it really was syncope was, were they aware of what was going on during the episode? Were they talking? Were they shaking during the episode? Was there actually a loss of postural tone? And was the return of normal mental status immediate or gradual? ACEP has a clinical policy for the evaluation of the patient with syncope, and it identifies a few groups of patients as being at particularly high risk of serious underlying etiologies. Patients with a history of congestive heart failure in particular have a higher likelihood of malignant arrhythmias, and other groups considered at high risk include older patients, those with structural cardiac disease or known conduction disease, and those with known coronary artery disease. Conversely, they also identify young, healthy individuals as being generally a low-risk population. However, there are a few things we should ask about to screen this population to find those patients that may have a more concerning etiology of their syncope. These include exertional syncope, such as one might encounter with a hypertrophic cardiomyopathy, otherwise known as idiopathic hypertrophic subaortic stenosis, a history of underlying cardiac disease, structural or otherwise, or a family history of sudden cardiac death that might be suggestive of something like Brugada syndrome or long QT syndrome. Personally, I would also add pregnancy to the list of things to screen for in young females as well. Over the last 15 years or so, several clinical decision aids that can help us risk stratify our patients who present with syncope have been developed. These include things like the San Francisco Rule, the Rose Rule, the Boston Rule, and none of these are perfect, but some of them may be helpful. As with all clinical decision tools, these are designed to be an aid to clinical decision making, but physician judgment still trumps all. If your spidey sense tells you that there's something going on with the patient, trust yourself and evaluate the patient accordingly. The San Francisco Syncope Rule, otherwise known as the CHESS criteria, is a clinical decision tool that was developed to help clinicians identify which patients are at high risk for adverse events following a syncopal episode. It's important to note that these exclude patients that had traumatic syncope, those that had seizure, or patients with alcohol-related events. The high-risk criteria identified in this paper included patients with a history of congestive heart failure, a hematocrit less than 30%, patients with an abnormal EKG such as new ischemic changes, a non-sinus rhythm, or evidence of conduction disease such as Brugada syndrome, long QT, or so on. Patients with shortness of breath or those who presented with a systolic blood pressure of less than 90 at triage were also found to be at higher risk. However, these criteria do not supplant physician judgment, and if you're concerned about a patient, it's completely fine to admit them even if they don't meet this criteria. In fact, there was a follow-up study done in 2005 that looked at this, and they found that the decision tool was not better than physician judgment alone. The Rose Rule was developed more recently and is another attempt at identifying patients at high risk for adverse events after syncope. Patients are considered high risk on the basis of 7 criteria, and admission is recommended for patients with any of these criteria, including a BNP greater than 300, bradycardia with a heart rate of less than 50, a rectal exam that's positive for occult blood, anemia, chest pain associated with the syncope, an EKG with Q waves anywhere but lead 3, or an O2 saturation less than 94 on room air. This rule is somewhat less robust as it has not been prospectively validated, and unfortunately, it doesn't have great sensitivity or specificity, with a sensitivity and specificity of 87.2 and 65% respectively. The Boston Rule was developed around the same time as the Rose Rule. Among the 362 patients enrolled with syncope, 293, or 81% of those enrolled, completed their 30-day follow-up. Of those, 201 were admitted, and there were 68 patients who either had a critical intervention or adverse outcome during the 30-day follow-up period. The rule identified 66 of the 68 patients who met the outcome for a sensitivity of 97% and specificity of 62%. Of the 2 patients that were missed by the rule, One had an episode of SVT that was successfully terminated and subsequently ablated, and the other had a transient episode of bradycardia that resolved spontaneously with no intervention required during 30-day follow-up. Quite frankly, I think that most of these criteria kind of fall into the "thank you, Captain Obvious" category, since I don't think anyone is going to send home a GI bleed patient or a patient with an obviously ischemic EKG. Plus, it's probably actually fine to discharge a young, normal, healthy patient that just got a little dehydrated and needed a liter or two of fluid and is subsequently totally asymptomatic. As with the last rule, multi-center validation is still needed before this can really be applied widely. Since this rule was published, there have been a couple of small studies that demonstrated a decrease in admission rates when using this rule without any increase in adverse events. However, these trials are small and really not adequately powered to validate this tool. ACEP's clinical policy also weighs in on who needs testing for syncope. In fact, the only test that they recommend for pretty much all patients in the ED with syncope is an EKG. I personally tend to include an AccuCheck as well, but really, your history and physical should be what guides the remainder of your decision making regarding who actually needs any testing. So what is the value of a head CT in patients that had syncope? There are a number of papers that have looked at this question, and overall, they show fairly similar outcomes. This paper looked at 283 patients that had syncope and also got a head CT. The etiology of the patient's syncope was found on the head CT for only 2% of patients that got the CT and less than 1% of patients overall with syncope. The key point in this paper was that every patient that had a CNS abnormality on CT as the etiology for their syncope also had an abnormal neurologic presentation, such as a seizure or a focal neurologic deficit. Here's another paper that looked at the same question and enrolled 202 patients with uncomplicated syncope. By uncomplicated, I mean that they excluded patients that had neurologic findings or trauma associated with their syncope, and they just looked at the folks that had isolated, transient syncope. None of the patients that got a head CT for uncomplicated syncope had any abnormal findings on their CT. And here's yet another paper. This one included 293 patients that presented to the ED with syncope, 39% of which had a head CT performed based on the attending physician's judgment. Of the patients that got a head CT, 5% were found to have an abnormality thought to have contributed to or caused the patient's syncope. This included 2 subarachnoids, 2 other intracranial hemorrhages, and 1 stroke. All of these patients were older than 65 years old, and again, each of these patients had some other abnormal finding on exam, such as an associated head trauma, a new onset severe headache that started with the syncope, or an abnormal neurologic examination. Basically, the bottom line here is that you don't need to do a head CT in every patient with syncope. The ones you need to think about doing a head CT on are basically what I call the syncope plus group. So they have syncope plus something else. If they have some other indication for a head CT, such as head trauma, abnormal neuroexam, severe headache, or they're anticoagulated, these are the patients where you may get a return on your investment by doing the head CT. So let's move on to ACEP's next recommendation. Advances in modern medical technology have increased the ability to diagnose even small blood clots in the lung. Nowadays, the most commonly used imaging test for this is the CT pulmonary angiogram because it's widely available in most hospitals and emergency departments. However, disadvantages of the CTPA include patient exposure to radiation, the use of IV dye, and high cost. In addition, imaging for pulmonary embolism has increased more than tenfold in the last 2 decades, but PE-related mortality has not changed. So we're imaging more, finding more tiny and probably inconsequential PEs, and subjecting more patients to radiation exposure, dye exposure, and the risks of anticoagulation without any clear benefit. In fact, there's some question that we may actually be harming more people than we're helping due to the complications of anticoagulation. I'm sure most of you have heard the acronym VOMIT, standing for Victim of Modern Imaging Technology, or possibly BARF, as in Brainless Application of Radiologic Findings. This is kinda true in the case of imaging for pulmonary embolism. So, ACEP's recommendation is to avoid CT pulmonary angiography in emergency department patients with a low pretest probability of PE and either a negative pulmonary embolism rule-out criteria or a negative D-dimer. So why should we care about any of this? In 1980, about 2.3 million CT scans were done in the US. According to the data from the National Council on Radiation Production and Measurement, in 2006, 67 million CT scans were done. This is a nearly 20-fold increase in CT utilization. Radiation exposure is known to carry a risk as well, and estimates of lifetime risk of cancer vary based on age, cumulative radiation dose, and gender. These are primarily based on population studies of those populations exposed to atomic radiation from nuclear disasters, so it's a little difficult to extrapolate the data. However, it is estimated that there will be one new case of fatal cancer for every 500 to 1,000 pediatric CTs performed. Considering that there are about 9 million scans performed on children annually, when you do the math, that's a whole lot of kids that will go on to develop cancer in their lifetimes that might not otherwise have. We scan a whole lot more adults than children, and it seems that what you scan is important as well, because metabolically active tissue such as thyroid and breast tissue appear to be more sensitive to radiation exposure than to other tissues. A paper published in JAMA Internal Medicine estimates that an additional 29,000 cases of fatal cancer will occur as a result of CT imaging performed in the US alone. The point I'm trying to make here isn't that CT scans are bad. They're good, they save lives, but we still need to be clinicians and make sure that the scans we order are actually necessary and that we're not ordering CT scans for convenience on people that don't need them. Since PE is such a huge topic in emergency medicine, we're going to spend some time talking about PE workup today, because avoiding CT scans really means knowing how to use these tools correctly. Can we safely reduce the number of CTs we order for this? Yes, we can. All we really need is a rational approach to the evaluation of pulmonary embolism. There are a lot of diagnostic pathways and tools out there like the Wells score, the PERC rule, even your own Gestalt, but clinicians tend to greatly overestimate the incidence and the risk of PE. Knowing what these scoring systems are and how to apply them correctly is key to the evaluation of these patients. A huge amount of research has been dedicated to developing tools and risk strategies for the evaluation of PE, so there's a ton of information out there that clinicians have to wade through. Figuring out how to make sense of all this information can be really challenging, and so the goal of this discussion is to just simplify it. We have a bunch of different tools available to us to help us figure out who has a PE and who doesn't. There are technically a few others than what I've included on this list, but this is pretty much the list we'll be drawing from on a regular basis in the ED, so I'm going to focus on what we're going to do and what we have the ability to reach for in the emergency department. I'm not going to talk about all of these in detail because that's really not the focus of this discussion. This talk doesn't apply to the hypotensive, hypoxic, sweaty, dyspneic patient that just had a hip replacement 10 days ago with a swollen leg. The group we're focusing on in this discussion are the low-risk patients, since these make up the majority of the patients we're looking at and working up for PE. In the US, the rate of positive CT scans for PEs is in the range of 4 to 6% on average, which means the overwhelming majority of patients we see don't actually have the disease. What we need is a better strategy to cope with this population. The best known risk stratification tool is probably the Wells score. The Geneva score is another one that's commonly cited, but the Wells score seems to be more commonly used and is a little bit simpler to apply, and has been validated in both the ED and the inpatient cohorts. However, notice that I called this a risk stratification tool and not a decision tool. Wells is not meant to diagnose or exclude PE, but to help guide workup by predicting the pretest probability of PE and helping the clinician decide if and what testing is appropriate to rule out the diagnosis. Lastly, these tools don't apply to everyone with a chest. These are only useful when applied to the correct population, which, in this case, is the population of patients in whom you think PE is a reasonable possibility. The Wells score is comprised of 7 criteria listed above that each are scored between 1 and 3 points. A patient with a score of 0 to 2 is considered low risk, whereas a patient with a score of 7 or greater would be considered high risk. ACEP also supports the use of this scale in a more dichotomous fashion, with 0 to 4 being low risk and 5 or greater being high risk. The biggest source of contention regarding use of the Wells score is the subjectivity of the no alternate diagnosis is more likely than PE criterion that alone makes the patient at least moderate risk and isn't an objective finding. The pulmonary embolism rule-out criteria, otherwise known as the PERC rule, was developed by Dr. Jeff Klein and is a decision tool designed to identify a cohort of patients that has less than a 2% pretest probability of pulmonary embolism. This is a little bit different than risk stratification, as this tool was developed with the intention of identifying a group of patients with such a low risk of PE that further testing just isn't necessary. In fact, you're probably at least as likely to get a false positive as a true positive in this population. The PERC rule does need to be applied to the correct population, which is the low-risk cohort, whether you stratify them as low risk by Wells or by Gestalt. These are people that are probably complaining of some pleuritic chest pain or maybe some subjective shortness of breath, but you think they're low risk, but PE is still a possibility. If this group is PERC negative, you're done, and you don't need to do any further testing such as D-dimer or imaging, and this has been prospectively validated in multiple centers, so it's ready for prime-time use. The pulmonary embolism rule-out criteria include age less than 50, heart rate less than 100, an O2 sat greater than 94 in a patient with no prior history of DVT or PE, no hemoptysis, no surgery within the last 4 weeks, no exogenous estrogen use, and no unilateral leg swelling in the patient. If all of these criteria are present, you have effectively ruled out PE in your low-risk patient, which is really nice because this is a heck of a lot faster than waiting for a D-dimer or a CT angio to get done. This is the meta-analysis published in the Annals that included 12 trials looking at the PERC rule. It's sensitive, but not that specific, which is pretty much expected since sensitivity is really what you want in a decision tool. PERC was pretty good and had a 97% sensitivity in the low-risk cohorts. This is comparable to the sensitivity of CT scanning in this population, which is generally reported between 92 and 96%. CT scanning is by far the most common test used to evaluate for PE, but is less sensitive than most clinicians realize. Some studies have reported higher sensitivities, but those studies have the problem that they lack a gold standard, and some of them actually use follow-up or CT as its own gold standard, which makes it difficult to know what the actual sensitivity is. The bottom line here is that the PERC rule has sensitivity that's on par with CT scanning, and you're unlikely to garner any additional benefit by adding additional testing once you've had a negative PERC score. Okay, so now let's talk D-dimer. D-dimer is a fibrin degradation product, and a small protein fragment is present after blood clot is degraded by fibrinolysis, and this is what you're actually looking for in the blood with this assay. In low to moderate risk ED patients, D-dimer measurement is a logical first step and allows PE to be ruled out in about 30% of patients, with a 3-month PE risk in patients left untreated of less than 1%. However, D-dimer should not be measured in patients with a high clinical probability, owing to a low negative predictive value in this population. As with any test, applying it to the correct population is key to using the test correctly. High-risk patients should just go straight to imaging, and D-dimers really won't help you in this group. Likewise, there's also little utility in sending a D-dimer on the super low-risk population, such as the PERC-negative crowd, because you're more likely to get a false positive result than any benefit in this group. We also have to consider 2 other special populations, which are pregnant patients and the elderly, as D-dimer assays may need to be interpreted differently in these groups. A number of papers have examined the increased risk of venous thromboembolic disease during pregnancy. About 80% of venous thromboembolic events during pregnancy are DVTs, and only about 20% are pulmonary emboli. About one-third of pregnancy-related DVT and half of pregnancy-related PEs occur after delivery. When DVT occurs during pregnancy, it's more likely to be proximal and in the left lower extremity, possibly due to the mechanical compression of the left iliac vein where it crosses the vertebral body as a result of enlargement of the uterus. We also tend to overestimate the risk of disease in pregnant patients, and so we tend to work them up more aggressively as well. In this meta-analysis of 17 studies including over 25,000 patients, the frequency of venous thromboembolic disease among the 506 pregnant patients tested was only 4.1%, compared with a 12.4% positive rate among non-pregnant patients tested. Because we tend to think more about venous thromboembolic disease in the pregnant patient, we tend to test more people, so we end up with a lower frequency of positive diagnoses in this population relative to the number of patients that we test. This really speaks to the need for a better strategy to evaluate these patients. D-dimer is well demonstrated to be elevated in normal pregnancy, and therefore, normal cutoff levels for D-dimer are likely to be exceeded by completely normal, healthy women simply due to the normal progression of their pregnancies. Based on this, a number of studies have looked at the possibility of setting higher D-dimer cutoffs based on what trimester of pregnancy the patient is in. In this paper, blood samples were taken from 23 normal, healthy pregnant women, both prior to conception as well as during each of their trimesters. When viewed on a scatter plot, the D-dimer levels in all of these normal healthy women increased throughout their pregnancies to the degree that no normal pregnant woman would be expected to have a negative D-dimer in the third trimester if we use the same cutoffs for what is considered normal in the non-pregnant population. When you look at the scatter plot of the D-dimers drawn from these patients, the increasing trend is distinct, peaking during the third trimester. Based on this paper concluded that D-dimer basically has no utility in ruling out venous thromboembolic disease in the third trimester if the standard cutoff is used. This paper is a retrospective study of 249 pregnant women, all of whom had suspected DVT. Stored plasma was available for testing in 288 of these, and all the women underwent compression ultrasonography with repeat ultrasounds on days 3 and 7 if their initial ultrasounds were negative. The majority of the patients presented with suspected DVT in the second or the third trimesters of pregnancy, and 15 of these were diagnosed with deep vein thromboses. DVT was the most common during the third trimester, representing 46.7% of all DVTs diagnosed during the study period. The authors performed testing with 5 different D-dimer assays, and all 5 of them exhibited consistent results, with values steadily increasing throughout pregnancy in the normal patients, but being significantly higher in the population of patients that ultimately were diagnosed with DVT. Although D-dimer levels increased several-fold throughout the pregnancy, they found that they could establish higher cutoff points with each assay and still preserve a 98% negative predictive value, which is equivalent to the test performance in non-pregnant patients with conventional cutoffs. This is a paper that found similar results, enrolling 1,131 pregnant women, and each of these women had D-dimers measured at weeks 6 to 14, as well as 30 to 36 weeks of gestation. Dopplers of the legs were also obtained between 30 and 36 weeks of gestation in all of the patients as well. D-dimer levels predictably increased significantly throughout the pregnancy, and mean D-dimer levels were significantly higher in women who were positive for DVT on ultrasonography. They found that they could maintain a negative predictive value of about 95.5% in ultrasound-positive women when the D-dimer was set at about 1.5 times the mean reference population. In this paper, 89 normal healthy pregnant women were enrolled as a reference group, and their D-dimers were followed throughout the pregnancy. Similarly to the Klein paper, pretty much all of the women had D-dimer levels that would be considered abnormal by the third trimester, and the authors agree that without using a higher cutoff, D-dimer has no practical diagnostic use in ruling out venous thromboembolic disease in this population. They also enrolled 12 pregnant women in whom DVT was suspected clinically, 10 of whom ultimately had a DVT diagnosed. All of the women that were diagnosed with DVT during pregnancy had a D-dimer that was substantially higher than the mean D-dimer of the corresponding reference population by trimester. The authors suggested new cutoff levels for each trimester, suggesting that for the first trimester, a cutoff 1.25 times normal, for the second trimester, a cutoff 2 times normal, and for the third trimester, a cutoff 2.5 times normal. So what about the other concerning population, the elderly? D-dimer also increases with age, and after age 50, an increasing number of patients will have an elevated D-dimer at baseline. Since 70 seems to be the new 50, numerous trials have been done to establish the new normal based on age and effort to create a strategy to age adjust the D-dimer. While we don't really worry about radiation exposure in the elderly, being able to order fewer CT scans would help us unclog that CT backlog that always seems to happen and improve patient throughput through the ED. Older patients are also more likely to have renal disease that may be problematic when contrast is needed, so it would still be nice if D-dimer worked in this population. This paper was a retrospective cohort study of a little over 5,000 patients all over the age of 50 that got D-dimer testing with subsequent imaging if their D-dimers were positive, and then the patients with negative D-dimers were followed up for 3 months. The study was divided up into 3 different cohorts, using a derivation set of 1,331 patients to establish reasonable age-adjusted cutoffs, and then looking at 2 separate retrospective validation cohorts and looked at retrospective data that was collected prospectively from a different trial. All the patients enrolled fell into the low to moderate risk category. This graph shows the optimal cutoff values for D-dimer testing for pulmonary embolism by age in patients with a low to moderate probability of PE with a sensitivity set at 100%, and there's roughly a linear increase by decade of life. The age-adjusted D-dimer that they used was basically based on age times 10, so if you had a patient that was 72 years old, their age-adjusted D-dimer cutoff would then be 720. All of the patients enrolled in the validation cohorts fell into the low to moderate risk categories. These cohorts both had a rule-in rate of 20% for pulmonary embolism, which is about 5 times the rule-in rate in the United States, so this may have been a sicker population than what we typically test for in the United States. The age-adjusted D-dimer performed well, however, and maintained a less than 1% false negative rate while reducing the need for CT imaging by nearly 20%. The differences in the false negative rates between the groups did not achieve statistical significance. However, as they were using retrospective data, they couldn't report on whether there was any clinical impact for the small number of patients that would have been missed. And despite a slight increase in the false negative rate, they still maintained better than a 98% sensitivity. With increasing age, specificity of D-dimer for acute PE decreases, resulting in a lower percentage of elderly patients in whom the diagnosis can be ruled out. This retrospective cohort study looked at patients being evaluated for PE that had a D-dimer and had CT angiography, and looked at a variety of different D-dimer cutoff points to see how the sensitivities and negative predictive values would perform. They examined a variety of different D-dimer cutoff points, including less than 490, less than 1,000, and less than an age-adjusted cutoff being age times 10. The mortality attributable to PE in this study was 6.5%. However, each of these patients also had a D-dimer greater than 1,000. I know this slide looks kind of busy, but bear with me. In this paper, when we look at different D-dimer cutoffs and figure out the sensitivity, specificity, and negative predictive value of each of the cutoffs, we can compare and see how each of these cutoffs performed. They used the normal reference standard of 490 and twice the normal reference standard of 1,000, and also tried an age-adjusted approach using the previously studied age times 10 cutoff. What really stands out is that the age-adjusted D-dimers worked really well in the age over 80 group, achieving a 100% sensitivity in this group. The age-adjusted D-dimer also performed very well in the group overall, with better than 98% sensitivity. It's also interesting to note that none of the patients in the age over 80 group had a level below the unadjusted cutoff. In 2014, the paper we really wanted was published in JAMA, a prospective trial looking at the utility of age-adjusted D-dimers. Patients were excluded if PE suspicion was raised more than 24 hours after admission to the hospital, or if they were already anticoagulated for another reason, if they had an allergy to IV contrast dye, renal failure, or if their life expectancy was less than 3 months at the time of entry. Patients with a negative D-dimer did not undergo any further testing and were left without anticoagulant therapy. Patients with a positive D-dimer underwent CTPA and were anticoagulated if the CT was positive. All of the patients were followed for 3 months, and the primary outcome was the failure rate of the age-adjusted D-dimer, defined as the rate of symptomatic thromboembolic events during the 3-month follow-up period among patients not treated with anticoagulants based on the negative age-adjusted D-dimer cutoff. The study ended up enrolling 3,324 patients, 817 of whom had a D-dimer below the traditional cutoff. Another 337 had a D-dimer that was less than the age-adjusted cutoff, whereas 1,744 had a D-dimer greater than the age-adjusted cutoff, and 426 were automatically thought to be high probability and went straight to imaging. Among the 810 patients that completed 3-month follow-up in the group with the traditional D-dimer cutoff, there were 2 deaths and 8 suspected PEs. Of these 10 events, 1 was ultimately confirmed as having a non-fatal PE, and therefore the 3-month thromboembolic risk in this group was 1 of 810 patients, or 0.1%. In the group with a negative age-adjusted D-dimer, no patients were lost to follow-up, and causes of death were as follows: 3 due to end-stage COPD, 1 from refractory ITP complicated by an intestinal hemorrhage, 1 was due to a metastatic cancer, 1 was due to terminal cachexia in the context of a psychiatric illness, and 1 was due to hypovolemic shock after a massive hemorrhage. Only 1 patient had a confirmed non-fatal PE, and therefore the thromboembolic risk in this group was 1 of 337 patients, or 0.3%. So overall, there were 2 PEs that were missed by the age-adjusted D-dimer cutoff. In both of these cases, it's impossible to know whether the patient had a PE at the time of initial evaluation, or whether the PE that occurred on follow-up was a new event at that time. However, the failure rate among patients that underwent a CT or other imaging study on the first visit was 7 out of 1,481 patients, and that indicates a failure rate of 0.5%. This means that the miss rate for patients that underwent D-dimer testing was essentially equivalent to the miss rate for patients that underwent advanced imaging. And this suggests that in this population, using an age-adjusted D-dimer is a completely reasonable strategy. So does this work in the oldest of the old? Overall, there were 766 patients in the study that were age 75 or older, and of these patients, 673 had a non-high clinical probability. The proportion of patients with a D-dimer level lower than 500 was 43 out of the 673 patients, or 6.3%. Another 157 patients, or 23%, had a D-dimer level that was lower than their age-adjusted cutoff. Therefore, the proportion of patients older than age 75 with a non-high or unlikely clinical probability and a negative D-dimer result using the age-adjusted cutoff was 200 of 673 patients. Of these patients, 5 received anticoagulant therapy for another indication other than venous thromboembolism during follow-up and were excluded. None of the remaining 195 patients had a confirmed venous thromboembolism during the follow-up, suggesting that again, this is a reasonable strategy even in the most elderly population. Unfortunately, there's one small problem here. Each of these studies that I polled used a different D-dimer assay, some of which were reported according to fibrinogen equivalent units as opposed to D-dimer units, and some used micrograms per milliliter versus micrograms per deciliter versus milligrams per deciliter, and the way these levels were reported is all over the map. That makes it pretty tough for the poor ED doc that just wants to take care of the patient. So I do think it's okay to consider using a higher D-dimer cutoff in these populations since there's ample literature to support it, but you'll have to figure out what assay your institution uses, and it would probably be a good idea to involve all the stakeholders at your facility, such as OB, critical care, so on, to establish institutional cutoffs so that everybody agrees and is doing the same thing. Frankly, What would really be cool is if we had some kind of standardization format in which the D-dimer level gets reported, similar to what we do with INRs, and that way we can all just agree as a medical community what's a normal and what's an abnormal D-dimer in these populations. One of the questions I get asked is whether there's anything out there to actually back you up if you do use something like the Wells score or the PERC rule. And the answer is you betcha. There's plenty of published data out there that validates these instruments for clinical use, and the ACEP clinical policy on PE supports your use of either clinical gestalt or the Wells score when risk stratifying your patient. Likewise, the most recent policy update also discusses the PERC rule. The ACEP clinical policy supports the use of the PERC decision rule to exclude the diagnosis of PE in young patients age under 50 who clinically have a very low risk for PE. If you document your thought process behind using a validated decision instrument, you're well protected and you have the weight of the college to support your practice. Another point that this brings up is the question of whether those tiny subsegmental PEs we find even have any clinical significance, and whether we even need to treat them. There's a growing school of thought that maybe the lungs are actually supposed to filter out some of those tiny little clots, sort of like a filter, so that they don't go to more important places like your brain. But I digress, and that's a discussion for another day. This is an example of a diagnostic algorithm that uses the available evidence and current guidelines to develop a rational, evidence-based pathway to help the physician decide if and how much work to do when evaluating a patient for PE. While this pathway uses the Wells score to risk stratify patients into risk groups, the ACEP policy says that your gestalt is just as good, so I don't think there's really too much downside in actually using your gestalt when deciding who is low to moderate risk. This doesn't have to be the exact approach you use, but it's a great example of how to integrate a complex amount of data into a reasonable approach. The caveat, of course, is that there is no such thing as a perfect test. PERC isn't perfect, neither is the Wells score, neither is the CT, the VQ, troponins, or any other diagnostic. At the end of the day, we have to have some sort of a rational approach that still makes sense based on the evidence and testing that's available without subjecting the patient to risks that outweigh the benefits of testing. As with any other medical condition, physician judgment trumps all, but this is a really good place to start that makes sense based on the current evidence and guidelines. The bottom line for evaluating a patient for PE is start where you actually have clinical suspicion of a PE. If your criteria to screen a patient is, does the patient have a chest, that means you're over-testing. If you have a reason other than the presence of a chest, then the patient starts down the pathway of evaluation. In low-risk patients, consider using your clinical criteria, like the Wells score and the PERC rule. And use D-dimer to help risk stratify those patients that are moderate risk, such as the low-risk patients who fail the PERC rule, or those that are automatically stratified to moderate risk using something like the Wells score. Reserve CT imaging for patients who are high risk or who have failed D-dimer testing, and likewise, don't send a D-dimer on patients that you know you're going to CT or VQ anyway because it's too nonspecific to rule in PE, so in those patients there's no utility to adding it on. Well guys, that's all I got. I hope that this was helpful, and I will see you next time.